no better time to have my next guest. That would be Dr. Bridge Bombi of Centric Health. He's a cardiologist in town, one of the physician owners of the Bakersfield Heart Hospital, as well as Centric Health. Dr. Bombi, how are you, sir?
Richard, I'm well. How are you doing?
I could not be better, Dr. Bombi. I'm in a good mood. I am chosen to look at this Biden administration coming in as a breath of fresh air. I think we're going to have a lot more focus on the coronavirus and the details of which I think the previous administration was distracted by any number of political events. My question for you as we start off is, where is your head when you see what you've heard from President Biden, and now Anthony Fauci is back on the team as well and holding the press conferences? What difference might this make in the rollout of the vaccine and the availability in terms of how quickly we can move with this?
Richard, we previously talked on multiple occasions about the response to how to coordinate the vaccine distribution and the whole logistics about it. And we've been pretty consistent in saying that there should be a centralized coordination, because decentralized approach leads to essentially reinvention of the wheel at every county, every state level, and that's not really constructive. The fact that there is going to be a centralized, coordinated response eliminates a lot of errors. But as far as the target is concerned of vaccinating 100 million people in 100 days, I think that's a very modest target, because right now we are close to that number. We are roughly vaccinating 1 million people a day. So to use status quo as a measure of success 90 days or 100 days later, I think is not very aspirational. The goal has to be about 2 million people to 3 million people being vaccinated a day. And that's an achievable goal. According to some measures, even the pharmacies can deliver up to 3 million dosages a day. Also, what I think is the fragility of the vaccine resulted in an overthink. The whole approach is upside down. After having started the vaccination project in two of our institutions, the Bakersfield Heart Hospital and the Centric Urgent Care, we are the lead vaccinators in Kern County. There have been only 14,000 vaccinations till this Tuesday, and 3,000 between Heart Hospital and Urgent Care. So that gave me a different perspective in terms of how best to approach the issue of vaccination. As I've said repeatedly, the thrust of vaccination has to be vaccination, not bureaucracy, not creating shackles for the healthcare providers. There should be guidelines that should be adhered to, but with flexibility. At the end of the day, the real goal is vaccination, because vaccinated human is a part of the solution, not part of the problem.
Wow. So you're talking about if 2 to 3 million a day. Let me ask you that, because all we hear about, and I heard Mayor de Blasio of New York City talking the other day, and they seem to be running out of vaccine. Do we have enough vaccine that's being produced to be able to vaccinate 2 to 3 million people a day in this country?
The combined number, the short answer is yes. So the combined commitment by Moderna and Pfizer is 20 million vaccines a week. So that is roughly 3 million shots a week. So we do have, I think, the manufacturing capability, and I learned today that the 1950 Korean War Act, Defense Production Act, is going to be initiated to further tweak the manufacturing, which I think is extremely desirable. I think we will have the manufacturing capability. Do we have the distribution capability. Do we have asymmetric distribution, meaning some centers which are unable to use the vaccine have vaccine on ice, others who have lines of people waiting for the vaccine? So those asymmetries, those distribution inequalities need to be addressed. For instance, in both our stations at the Heart Hospital and the Centric Urgent Care, we have committed people, but we don't have the vaccines. We have 3,000 people waiting at the Heart Hospital and about 1,000 at Urgent Care, and we're running out of the vaccine. And that's a shame, where the vaccination is the last piece, that is the last mile. That's where the bottlenecking occurs. When we have resolved, or we have at least addressed that piece very efficiently, the access to vaccine should not be a problem. Even in Kern County, I don't know the mechanics. Till Tuesday, we had roughly 50,000 shots distributed to Kern County, and only 14,000 were in people's arms. So the whole mechanism, the whole logistics should be geared towards having the vaccine in people's arms. Nothing should come in between. Not politicians, not impediments.
Right. We're talking to Dr. Bridge Bombi of Centric Health. Dr. Bombi, what is, let's use Bakersfield as an example, because we all live here and we're familiar with it, and it's the size of a community. It's not a small community, but it's the size of a community we can all get our arms around. You look around, you look at other areas like Dodger Stadium, and you see the lines there, and they're talking about people are getting vaccinated, but some of them have to wait 5 hours in their car. What can we expect? Or we haven't seen that here. Is there a reason we haven't seen that here, or is it simply because we're a smaller community, or do we have more distribution sites for people to get the shots?
I would be guessing, but my guess would be that we haven't opened up a stadium that size. We haven't created that demand and supply opportunity for the lines to be formed. But going back to the most optimal way of vaccinating people, I think, is to look inside the box. What happened, as I said, with the fragility of the vaccine, people tried to think outside the box and discover different metrics. At the end of the day, Richard, if you had an access to vaccine with your primary doctor, you have declared previously Dr. Raj Patel, you wouldn't ask anybody a question. You would ask his office, hey, when can I be there? And that's eminently doable. What we have created is an artificial crisis. If we make the vaccine available, let's say you're talking about local, so let's talk about Centric Health. Let's say they allow us to distribute the vaccine to our clinics. We have 20-some clinics in our part of the world. So if we have one place, which is a repository where we keep the vaccine, once it's thawed, there are 5 hours to distribute to vaccine. That's a long enough time. Even if I have to deliver the vaccine to my Tehachapi clinic or Delano clinic, I can do that. If there are 20 people lined up there, there will not be a drop wasted. What has happened is the bureaucracy, in its desire to assert control, have created artificial impediments. And I keep saying that the logistics, the bureaucratic logistics shouldn't be layered to impede. They should be streamlined to succeed. What we need to do is we need to have vaccine repository where it's preserved in a cold environment, but it's available to be distributed to all the subclinics. The clinics at a smaller level, they don't need to be authorized. One authorized place can sublet to others, and it could be those clinics could even participate in networking with other lesser solo practitioners and things like that. Right now, we're thinking outside the box. The solution in this case is inside the box. The existing network of physicians and providers is the right way to go. Also, when you go, Richard, to let's say even Centric Urgent Care, a new patient over there has a new chart to be formed. There's an extra amount of work that goes in creating a new chart, And the cost the government pays $20 per vaccination doesn't come close to being the cost that's being incurred by the person who's supporting that. And then additional liabilities, the economical liabilities, the business liabilities, if somebody slips in the parking lot, for instance. The government doesn't take the liability. The person, the Good Samaritan who's helping vaccinate people takes the liability. And I think what is a better way of saying it? It's the cart before the horse.
Yeah.
And what we need to do is go back inside the box, maximize the existing network of physicians and corner pharmacies. We can get this thing done the right way quickly, because this vaccine doesn't die in seconds and minutes. It gives us good 5 hours on room temperature.
I was curious why, when I called Dr. Patel's office when this first started, and my group was getting ready to be called, and they said no, check, that they mentioned Centric and someplace else, and I was curious, like, why wouldn't I be able to get it from my private physician? And it's
your benevolent bureaucracy going overboard. It's an overthink on their part. They need to slow down and let the people, the foot soldiers like me, who treat patients one at a time, maybe we have a better idea than the high-powered thinkers in positions of power.
Yeah, absolutely. What about, I may have asked you this last week, but I want to ask it again for folks who maybe weren't listening last week. But is there a chance where people who have gotten the first shot and are waiting either the 3 weeks or 4 weeks, depending on which vaccine you get, for the second shot, if there's a rush on the vaccine and there's not enough for the second shot, how long can you wait for that second shot before? What if instead of waiting 3 weeks, you have to wait 6 weeks? Is it going to matter?
So, Richard, it's a good question, and as you mentioned, we have addressed it previously. The only reason Pfizer took 3 weeks separation and Moderna took 4 weeks separation is because they were rushed for time. So the time dimension was compressed. Typically, the booster dose is administered 8 weeks or later. So most people agree, because this isn't it's not evidence based. It's based on extrapolating our previous experience to this vaccine. So if we spread that distance, the separation to 6 weeks or 8 weeks, I don't think it hurts. On the contrary, it may even help. It may give a better booster response if the dose is delayed. But at the very least, at least on paper, it seems like a reasonable thing to do. And also, on the same lines, actually, by the way, CDC today declared that the separation could be 6 weeks. So they did mention that today.
Okay, interesting.
And also, other thing I disagree with CDC is that they are saying people who have been previously infected should be in line to get the vaccine. I say they should be at the end of the line because there is enough evidence that people who've been infected by the virus are unlikely to be reinfected. There was a study in England of over 6,000 people, and the reinfection rate was less than 1%.
Wow!
And if you compare that, Richard, here's the real deal. If you compare that with the efficacy of the vaccine, it's 95%. So meaning 5% of the people who are vaccinated can have the virus again. Only 1% or less with the natural infection. So why are we wasting our dosages on people who are previously infected? They should get the vaccine, but they should be put at the end of the line. So in this country, for instance, let's do the math. We have a little over 300 people, 300 million, 330 or some million people, and about 100 million are 18 or younger. So that leaves you 230 million people. Out of the 230, you take the 30 million who had the infection, it leaves you 200 million people. So if you really cut to chase, 200 million people we should be able to vaccinate through July with both the shots. If somebody with clarity of thought and ability to execute is running the operations.
So interesting talking to Dr. Bridge Bomby. Dr. Bomby, the mutations of the vaccine, and you hear about this mutation from London, then there was another one from South Africa. And when the layman hears about these things, it sounds so sinister, and you think, oh Lord, we're going to have to start all over again. Can you educate me on how and why these vaccines mutate, and generally when they do, are they is the original vaccine, at what point does the original vaccine become ineffective after multiple mutations, or does it?
Richard, the good thing with COVID-19 is it has a larger genetic footprint. So the large genetic footprint allows proofreading. When the virus replicates, it makes sure that it replicates exactly like itself. The fact that its genome, genetic material, is more evolved than flu or a Hep C virus, it's able to maintain fidelity of its genetic structure. But given the amount of opportunities it has, trillions upon trillions upon trillions of times, gazillions of times in the world, because of rapid spread, there are expected variations, the errors rather, in genetic replication occur, and sometimes those errors can be in places that actually give the virus an evolutionary advantage. The evolutionary advantage being that the virus connects to our cells through spike proteins, and those spike proteins can be rearranged in a way that they latch to our cells much more effectively. When they latch onto our cells much more effectively, they're able to spread better, and the virus becomes more contagious. What we haven't seen yet is any change in lethality for the worse. But what happens is when a vaccine is made, it does cover a fairly substantial part of the spike proteins. So minor changes are unlikely to impact the vaccine's neutralizing abilities. But it's a theoretical possibility. It's a theoretical possibility that in the next year or two, there could be what's called the antigen drift, that there would be sufficient change in the spike proteins that it will escape or evade neutralization by the existing vaccines. So that's why there is a rush. There's a race to eliminate the infections so that the possibility for it to create mutants that we have to rebattle is lessened. Advantage again is that because of the messenger RNA-based vaccines, we are able to adapt the new vaccine to the next mutant. It's a fight we'd rather not have. We'd rather vaccinate faster and not allow it to replicate.
Yeah, absolutely. We're almost out of time, but I want to follow up with this question. When you talk about fighting the battle again, and refighting the battle again with these things, because most of us, I mean, you're a scientist. I mean, it's your business. It's your field of study. It's your life's passion. It's your life's work. But for most of us, not. So my question is, are we, now that we've had a brush with a very, very deadly vaccine, more than a brush, by the way, I didn't mean to underplay it, but is this going to be something that's going to live with us forever, in the sense that it's going to change behavior of how whether we shake somebody's hands, the design of an eating space in a restaurant, is there going to be, if society is smart, is it going to be a different look in the way that we behave with other people and eating out as never before, or will we conquer this and kind of go back to the old normal?
Well, I think the human memories are short, and the tools we have to fight the virus with the vaccine and all are pretty robust. My guess is we probably will gravitate towards our old behaviors, and which is fine. But this virus was actually a test run for the next one that's going to come. That's going to be way more lethal and probably more contagious. in the process we have developed science that will be prepared for that. So I feel optimistic that we will be able to win this battle and be ready for the worst one.
Wow, I mean, I had to write down what you said. It's a test run for maybe the next virus that would be more lethal and more contagious. Boy, that's a scary thought, though. But let's get one battle at a time here, I guess.
But forewarned is forearmed, so I think we will
absolutely
be able to handle it.
Absolutely. Dr. Bridge Bombay, everybody. Thank you, sir. Hope you have a great weekend. Get out for a run, and we'll be talking to you next week, Dr. Bombay.
Appreciate it. Stay safe.
Okay. Thank you, sir. Appreciate it. 227.